afternoon, ladies and gentlemen. Nice to see you all here. You know who I am. I'm a practicing rheumatologist in the UK. I look after about 120 patients to 150. It varies a little bit from week to week. Antibodies are getting more and more important to us in terms of diagnosis, and I want you to understand, my job this afternoon is to make you understand what antibodies mean. Now, it isn't just about labeling subsets. They may be very important etiologically as well. So as we go through the talk, you'll see how I've tried to link it to possible mechanistic insights. We've got quite a lot to get through, so I would prefer if you didn't shout out questions during the talk. There'll be plenty of time at the end to ask lots of questions. So here's the classic picture of myositis. This is a cross-sectional biopsy. Here's individual muscle cells, and you can see that most of them look healthy, but at this place here, you can see there's T cells which are invading the surface of this muscle cell. Not only that, they've actually breached it, and here you've got T cells and macrophages invading a so-called non-myocrotic cell. And that's the classic picture that we see. And of course, this inflammation causes weakness and myalgias. So because it's painful, that's why patients with myositis come to a rheumatologist. So the outcomes are variable, but often poor. Patients can succumb to complications, so respiratory or right heart failure can occur, and patients with associated malignancies, of course, can succumb to the malignancy. But even when patients, and the majority of patients don't die, of course, but even among survivors, the majority, more than 75%, remain disabled because of ongoing weakness or breathlessness. The disease mechanisms underlying myositis are actually rather poorly understood, so myositis remains a therapeutic and an academic challenge. Now, mechanistic research is difficult because, as I said to you earlier on, myositis is rare, so most UK rheumatologists will only see 5 or 6 cases in the whole career, so it's really difficult to do research into myositis. Now, myositis is a complex disease. There are familial aggregation studies where there's more than one case within one study, so we know genetic factors are involved, but there are environmental triggers. You saw Dr. Raju talk about them this morning. So we know about UV, we know about the possibility of drugs, and of course, cancer can be associated with myositis. So when I came into myositis research 12 years ago as a rheumatologist, these were the traditional, inverted commas, types of myositis. I'd see polymyositis and dermatomyositis. So there are clinical differences. Dermatomyositis, of course, have got the very characteristic heliotrope rash. Polymyositis patients don't get that, of course. And then you've seen this picture already. In polymyositis, it's CD8 positive T cells which invade the cell surface. In dermatomyositis, you get this peculiar perifascicular inflammation, which may mean that in dermatomyositis there's damage to the circulation to the muscle. And of course there's a difference in outcomes. Cancer-associated myositis is much more common in dermatomyositis, so this is the biggest risk for a fatal outcome. But interstitial lung disease can kill you of its own accord, or it can cause right heart failure. Anti-SRP antibodies mean usually that you have a much more severe type of disease which is poorly responsive to treatment. So 2 or 3 years into my journey in myositis, I realized that kids got dermatomyositis, and these are the 2 complications which the pediatricians fear. If you get calcification in the muscle and the calcification goes across a joint, that means the joint won't move. They get a contracture. And the other thing that kids get, which adults don't usually get, is this horrible ulceration. So, and of course, sorry, I'll come back. It hasn't been known up until recently how to predict which kids got which of these complications, so you couldn't target treatment for individual patients. IBM, everyone's never really known where to put IBM. If it looks like anything, it looks like polymyositis, which is why I put it up there. But of course, you can get myositis overlapping with connective tissue diseases. I put that slide in to remind me to talk about IBM. IBM has a characteristic weakness affecting the forearm flexor muscles and the tibialis. And this peripheral nature of the characteristic muscle weakness makes patients look as though they've got a peripheral neuropathy. And it's often the case that patients with IBM don't have muscle pain. So if you haven't got myalgia, you wouldn't seek out a rheumatologist. So within the UK at least, most IBM patients initially find their way to a neurologist. So why test for antibodies? So MSA is myositis-specific antibodies, MAA is myositis-associated antibodies. Testing is expensive, so there's no point in doing it unless it's going to be any good. Even our own routine immunology lab only gives us one MSA, that's anti-Jo1. If there is another antibody present, what does it mean? And if there is another antibody present, or if there's Jo1 present, what does it mean in terms of case management? So these are ways that you can detect antibodies. So this is the assay that we use in Hope Hospital in Salford. You see that SM, RNP, Rho, and LA are all potentially found in lupus, mixed connective tissue disease. SCL70 is found in scleroderma. And so Jo1 is the only myositis-specific antibody. This is a new method that we're trialing, so it's 3 times more expensive, but you can see that it's got these other specificities on. It's got the anti-Me2, it's got SRP, and these other anti-synthetases. But the gold standard is immunoprecipitation, and I'll show you some slides later on to show you what that looks like. So in my original work, I correlated with Chet in Pittsburgh. More recently, I've been correlating with somebody in the UK, Neil McHugh. But this is the gold standard used for research. It's much more expensive and it's very time consuming. It takes about 2 weeks to plate these out, and then you have to run the plates for a week, and then you have to develop them and then assess them. So it's about a month before you get a result. So it's very labor intensive. So until recently, we had to pay for all these separately from research funds. So we didn't get them on a routine basis. This is what immunoprecipitation plots look like. These are gels, and because of electrophoresis, the proteins run up the column, and this first column is a normal one. So you can see there Jo1 has got a band there which isn't there. PL12 is a very prominent band there. PL7, etc., etc. And these are the MAAs. So even once you've got the result, it's got to be interpreted by a human being to compare it with an experienced human being at that. So I'm just going to, in this early part of the talk, I'm going to flip backwards and forwards to genetics. You'll see the importance of it later on. So what do we know about myositis genetics before 2000? Well, we knew about familial aggregation. There were 35 reported cases where there was more than one family present. But we also knew that autoimmunity was markedly elevated in first-degree relatives of patients with myositis. But myositis is so rare that there are no twin studies published to date. Now, this is the HLA. This is HLA on chromosome 6, and these DR and DQ genes are the ones that have been studied again and again and again in autoimmunity. So rheumatoid, diabetes, etc., etc. These genes are all implicated in that process. So we know that myositis is an autoimmune disease, so it was obvious that we should start with HLA. So this was before 2000. This was Lisa Ryder and Fred. They showed that HLA DRB101 and HLA DQA 10501 were both significant risk factors. Now, just to orientate you, these are odds ratios with 95-degree confidence intervals. To interpret these, that's about 10 or 12. This is the 95% confidence interval, and because it's above 1, that means it's a significant risk factor. If the footer goes over the one line, this means that although there's a trend for that to be significant, it's not actually significant. So what they showed was that the strongest signal was HLA DRB103, but this wasn't seen in Korean patients, illustrating that genetics goes across different races. But what the group they were collaborating with also showed was actually these odds ratios are much higher if you stratify by the antibody instead of by the genes. So the odds ratio there, look, is about 10 for DRB103, but here it's much higher, 20, 10 for JO1 and PMSCL. So the antibodies seem to be much stronger signals indicating disease. So in 1999, Fred Miller suggested this for the first time. He suggested that actually, rather than having traditional myositis subtypes, polymyositis, dermatomyositis, that in fact you should classify by antibodies. So the Anti-Synthetase Syndrome is the combination of Raynaud's phenomenon, arthritis, myositis, and interstitial lung disease. And interestingly, patients with Anti-Synthetase Syndrome, they get quite bad arthritis, and they're often misdiagnosed as rheumatoid at the beginning. SRP associates with a very aggressive myositis, which can even affect the heart, and SRP patients classically don't respond to therapy, and I'll show you a patient later on with that. And then the Me2 antibody specifies for the very classic dermatomyositis pattern, and with a relatively good outcome to treatment. So here's the first evidence that antibodies are better than traditional clinical phenotypes for saying what sort of patients you've got. So here's the Anti-Synthetase Syndrome, mechanic's hands with broken skin on the thumb border of the index finger, with Raynaud's phenomenon, with damaging joint problems, and with interstitial lung disease. And of course, it's the interstitial, so after cancer-associated myositis, having a synthetase such as JO1 is the next worst prognostic feature, because patients with interstitial lung disease can either die from their interstitial lung disease direct because they can't transfer oxygen, or they go into right heart failure. I should say, however, it's quite compatible. Within myositis, if you treat the interstitial lung disease very aggressively, it does usually respond to treatment. So you've seen that diagram already. So here's someone with, this is one of my patients, she's 36. She's got aggressive drug-resistant disease. She's on triple therapy with high-dose prednisolone, 40 milligrams. The textbooks say start with 60 or 80 milligrams. I never do because that's so damaging. But if I think someone's got bad disease, and I already knew that SRP was bad for you. So this lady finished up being on methotrexate and cyclosporin at the same time. And despite all those treatments, you can see this is a standard MRI scan. This is a stir image, and the white stuff is inflammation. So you can see that her hamstring muscles are heavily inflamed. The quadriceps is also inflamed. But you can see here that the muscle hasn't completely atrophied. So if we can only suppress this inflammation, we'll be left with healthy muscle. So she actually went on to have rituximab. In the UK, we're not allowed to give rituximab unless by compassionate, because it's got no license, because Chet hasn't published his paper yet, you see. So until he publishes his paper, we can't use it in the UK, except for compassionate use. So she did have rituximab on compassionate use, and actually she did do reasonably well. So, and then of course, the last mannequin is the classic Me2 one. So here's periorbital edema with the heliotrope, classic rash, shawl sign, and of course the very characteristic dermatomyositis on the back of the hands. So in conclusion then, at this point, myositis types represent a spectrum, disease spectrum, where the clinical subtype appears to be defined by the detected antibodies. Okay, so this is adding to the evidence that antibodies are important. Now, those early studies did have problems with them, though. They had small sample sizes. The biggest study only had 153 cases. And in that study, they put together Caucasian, Afro-Americans, Jewish, and Hispanic patients, obviously to gain statistical power. These were compared against controls, of course. And not only that, they pulled DM, PM, and even JDM to try and generate sufficient statistical power to show differences. So in 1999, 2000, having come back to Manchester, and as I've said to you already, the biggest clinic in the UK only had 44 patients. So the only way we're going to be able to get more power was to recruit patients, and the only way to do this was to tap up my colleagues throughout the UK, and these are all the centres. This is not up to date, there's more dots on this now. But by 2006, we had 282 patients, which, for a disease as rare as this, is pretty good going. Now, the research strategy was to correlate myositis subtype, phenotype, with a myositis serotype and genotype at HLA, DR, and DQ in large cohorts of UK Caucasians. We have collected blood from all sorts of races and inter-races, but we just haven't analysed them. We've chosen in the first tranche to only look at Caucasians because we want to try and make the groups as homogeneous as they can be. The antibodies were performed by Chet and Noreen. The green ones are the research antibodies which would only be detectable by immunoprecipitation. And here's the results of the first 280 cases. So JO1, in every study, JO1 is the most common. I think the thing that surprised me the most was I'd always conceptualized that JO1 was much more common in polymyositis, but you can see here that it's just as common in dermatomyositis as it is in polymyositis. These other synthetases are there in very small numbers, much rarer than JO1. Me2 is almost exclusively a dermatomyositis antibody. There's SRP, which isn't quite, but is much more common in polymyositis and dermatomyositis. So we're going to get off the genetics in a minute, and you'll understand where I'm going shortly. So this is what we found. So this is our results now, rather than Fred's and Lisa's. This is 282 UK patients, and this is DRB103, which is highly significant, 4.5 with the footer well above 1. This is DQA 105, and that's what Fred and Lisa had shown. This one hadn't been shown before, and nor had this one. And if we now compare DM with PM, so this is what Fred had found, this is what Fred had found. They hadn't looked for this. So this was the first time anybody had genetically shown that there was a difference between PM and DM, and it was at DRB107. So linkage disequilibrium. This describes the process by which contiguous genes, that means genes next to each other, are inherited intact together over multiple cell divisions more often than would be expected by chance. So when a cell divides, the DNA could go anywhere, but when LD occurs, the genes are so tightly packed together and so closely associated they go over as a bunch. So you can get trays inherited. So we go back to our HLA. And so here are the common haplotypes in a British Caucasian. So sorry about this. So what this means is this is DRB104, DQA103, DQB103. So 433 is the commonest haplotype. So a fifth of UK Caucasians have got that. Now, if you go across and now subdivide patients according to, so overall, PMs have got the same as normal. Overall, DMs have got more or less the same as normal. But as you shoot across, you get to U1RNP, and you can see there's an obvious enrichment at 37.5. U1RNP is the antibody that types for mixed connective tissue disease. Okay, 352, so that's DRB103, DQ5A105, etc. So 16.5% in controls, but you see patients with anti-synthetases like JO1 got nearly 50%, and people with PMSCL antibody have got more than 50%. What that means is that everybody in this population has got one copy of this, and 5% of patients have got two copies. In other words, they're homozygotes for this haplotype. And then if you screen down to 722 and move across, 9% in the normal control population, but 33% in Me2 patients. So if we just look now at this, the 352 haplotype, this is what's been expected. So this is PM and DM positive, as you'd expect. But if you actually split up by antibodies instead of by genes, you suddenly find that these odds ratios are enhanced dramatically. So JO1, so this patient group here are polymyositis and dermatomyositis, but they're enriched for JO1 because that's what you're stratifying by. If they've got JO1 and interstitial lung disease, this is even higher. If you take JO1 out of the population, it looks a bit like dermatomyositis, and the highest odds ratio was for PMSCL. So if you contrast that with the 722 haplotype, you'll see that I've already shown you that it's a protective factor for polymyositis. But if you split up dermatomyositis into those patients who haven't got Me2 versus those that have, you can see that it's the ones with Me2 who are the risk factor. So here we have class 2 haplotype, the 352 and 722. So if you've got 352, you've got an increased likelihood of getting polymyositis or dermatomyositis. You may get an anti-synthetase and ILD, and it could be mediated through 2 antibodies. If you get the 722, you won't get PM, you will get DM, you won't get a synthetase or ILD, but you will get anti-Me2. So this is the 433 haplotype, and I've already shown you the increased level of U1RNP. Now that's not significant because this is a small patient group. And the same with SRP. SRP, it goes together with the 216. So what we need to do now, of course, is we need more mannequins because RNP is associated with mixed connective tissue disease, which is a completely different disease to JO1 positive myositis. Mixed connective tissue disease with myositis is a much better prognosis. If you get mixed connective tissue disease with a bit of myositis, it will respond well to treatment and you'll do well, which is totally different to, say, SRP. So these antibodies are able to predict what sort of disease you've got. And if you get PMSCL, you get scleroderma myositis overlap or scleromyositis. So in conclusion to this bit, IMs represent a disease spectrum where the clinical subtype, including the antibody, appears to be defined by a class 2 haplotype. So the genes are governing what the disease looks like, as well as governing what antibody is being produced. But we only had 282 cases, and we've already said the importance of power. So we've pushed on now. This is the adult onset immunogenetic collaboration, AOMIC, and I think we're up to about 700 cases now. Now, I think Ingrid said earlier on, but if she didn't, I think I said it. We've formed in Europe a European myositis network, and you can see that we're around about 800. Jerry said he got about 350. Ingrid's got 130. Kathleen Danko, who hasn't been to this meeting, has got 350. They've got some in the Netherlands, and through our collaboration with Lucy Wedderburn of the Juvenile Dermatomyositic Research Group, they've got about 270 juvenile cases. So we're beginning to get numbers high enough that we can correlate genotype and phenotype to see if there are other significant associations. Now, here's a case study. There's a 49-year-old male with progressive shortness of breath. His CK was normal, his muscle strength was normal. His chest physicians were contemplating doing an open lung biopsy, but the trainee sent off blood for antibodies, and he was found to have an anti-ZO antibody. And he was treated with aggressive therapy with steroids and intravenous cyclophosphamide. So he has anti-ZO positive anti-synthetase syndrome without myositis or amyopathic PM. Amyopathic DM is DM without any muscle involvement. So in the literature, amyopathic PM hasn't even been written up as an entity yet. So I'll show you a slide shortly. So anti-ZO is just another one of the synthetases. There's now 8 synthetases described, and they can all be associated with interstitial lung disease and or myositis as part of the anti-synthetase syndrome. So here's the anti-synthetase syndrome. You've seen this already: mechanics hands, Raynaud's, destructive arthritis, and interstitial lung disease. So here's the synthetases. JO1, this is the one we all know about. Here's ZO. ZO is named after Zoe Betteridge, who works with Neil McHugh in Bath. You've got to call these antibodies something, and this is the only one that she's discovered, anti-synthetase, that is, so she called it anti-ZO. But as you go round the corner here, it becomes progressively unlikely that you'll get myositis and progressively likely that you'll get interstitial pneumonia or ILD. So classic Raynaud's, of course, have got all these, but we're noticing increasingly from referrals from the ILD clinic, the interstitial lung clinic, which the physicians run, that some patients have got antibodies which the consultant chest physicians didn't even know about, because of course the routine testing doesn't look for any of these. Now, I'm going to skip that bit. Now, no, I can't actually. Sorry. So I've already shown you that DRB103 is associated with myositis, and especially in patients with Jo1 and other synthetases. But DRB1 is also associated with PMSCL. Now these two conditions are very similar. Mechanic's hands, Raynaud's, arthritis, and interstitial lung disease. Patients with PMSCL get interstitial lung disease, they get Raynaud's, and they get skin changes, but they're more likely to be those of scleroderma. So although they're similar, if you're not looking very, very carefully, they're not actually the same disease. So, these genes here are in very close linkage disequilibrium. DP is on the other side of what's called a recombination hotspot. Within the immune system, you need to be able to recombine in lots of different ways to be able to have the ability to detect viral and antigenic bacterial components. So you need lots of ability to chop and change through divisions. So DP is very important. It's got 70 alleles, and it's very important in renal transplantation. And this was a study that we didn't have to pay for because it's already available on the NHS through the transplant physicians. So we looked at DP. So the yellow is DRB103, DPB101 is in green. So if you look at all cases together, DRB103 is a risk factor. You've seen that already. But DPB101 is also a risk factor. So if you take PM out and look at it individually, that's still significant. DM is not quite significant for this allele, and JDM, it's a risk factor. But if you then do it by antibody, so I keep showing you slides where it's the antibody that tells you the differences rather than the genes. So this is PM, you've already seen that. This is DM, you've already seen that. If you split it up by antibody, you see that the DRB103 becomes much more significant, nearly 20 odds ratio. Sorry. But the DPB1 is also a risk factor. But for PMSCL, this splits up these cases. So this is the first evidence that alleles outside of DR and DQ exert subtle effects on antibody production and therefore on the clinical phenotype. And these antibody association differences suggest that gene-gene interactions may be involved in determining clinical features. So now this is an aside, but it's all to do with antibodies. This is a study in rheumatoid by Lars Klarsgaard and co. Lars is Ingrid's husband. He works in the Karolinska. So it's not very easy to read, but this is the shared epitope is DRB104, and this is the gene that's been associated with rheumatoid. So if you don't have DRB104, the shared epitope, you're not likely to develop rheumatoid. If you have a single copy of the shared epitope, you've got an odds ratio of about 3.2. If you've got two copies of the shared epitope, you've got an odds ratio of about 5. However, if you now take into account smoking, if you smoke and you've got the shared epitope, you're twice as likely to get rheumatoid. And if you've got two copies of the shared epitope and you smoke, you see the odds ratio goes up to 20. So this is evidence of a genetic environmental interaction. Now we've done the same in patients with myositis. The patient numbers are small, so although they're significant within the group, they're not significant overall, but these are important trends. So if you've never smoked and you've got DRB103, the risk gene for myositis, you're said to have an odds ratio of 0. So that's your comparison group. If you've never smoked, but you're DR positive, then you're more likely to have Jo1. So there's an enrichment of Jo1 here. But if you come down to smokers who are DR103 positive, you can see that almost half of them have got Jo1. So smoking appears to be associated with an increased risk for the development of anti-Jo1 antibodies in DRB103 positive patients. And this suggests genetic environmental interactions to increase susceptibility for the disease. Now, cancer-associated myositis, you all know about this, but I'm going to show you now what the antibodies that are so important for this condition. This are our 282 patients, the original analysis. There were 26 patients with malignancy, but you probably know that cancer-associated myositis is said to be cancer occurring within 3 years of the onset of the myositis. So if we now look at CAM rather than malignancy, so out of a total of 282 patients, 16 had cancer, but only one of them was polymyositis. The other 15 were all DMs. So you all know that it's DM that's associated with its highest risk. So if we look now by routine antibodies, so here's your non-CAMs, Jo1 about a quarter, these other antibodies, but about a half of patients had no antibodies. In the CAM group, there were 2 anti-RMPs and MAA, but there were no other antibodies detected, and it's been recognized for a long time that if you have got dermatomyositis and you're older and you have negative routine antibody testing, you've got an increased likelihood of getting cancer. But here's the 155-140 antibody in red. This is now comprehensive research immunoprecipitation by Chet. And you can see that within the non-CAM group, there are 11 patients with this antibody. They're all dermatomyositis patients. But you can see that half of the CAM group had this antibody, the 155-140 antibody. So here's a marker for the first time that links with cancer. That the problem is, for everybody, including in America, that at the moment, this antibody, the 155-140, can only be detected by immunoprecipitation. So when we do our antibodies, we batch them off and send them now to Bath, and they can only do the analysis on them when we give them some money. So this is not paid for out of the NHS. This is not a service. This is done for research purposes. So I have to save up money on my endowment and then send them enough money to analyze 100 cases. So I might find someone's got the 155-140 antibody 3 years after I've taken the blood from the patient. So for them, that's not particularly clinically useful. But I was at a meeting recently, and the Spanish group look as though they've managed to find a way to make a cheap and cheerful test for the 155-140. So that'll be very, very important in the future. So if you've got the antibody, your odds ratio of having CAM is like about 22. So if you've got dermatomyositis and you're older, then you've got 20-fold increased likelihood of having cancer. So this is going to be a very, very important test. If you've got no detectable antibodies by routine testing, you're about 7 times more likely to have CAM. So an absence of antibodies on routine testing in older DM patients should arouse a suspicion to the presence of current or future development of CAM. So that's as good as we've got in clinical terms at the moment. 155-140 testing defines a specific CAM clinical subgroup, and we just need a proper test. Here's the individual cancers, 7 different types. So the notion that it's all gynae or all breast, just doesn't bear out. It's all sorts of cancers, and we've only got a population of 15 that we were looking at. So just to give you a feel for how these antibodies type for clinical status. So here we've got interstitial lung disease as a clinical feature. So obviously 50% of the Jo1 positive patients will get interstitial lung disease, 25% patients with PMSCL. Nobody with Me2 gets interstitial lung disease, and there's just 1 out of all the 155-140 positives. If you now put in cancer-associated myositis, there's a great risk in these patients. We don't know what the Me2s mean yet, but you see, if you've got Jo1, you're not going to get cancer, and if you get cancer, you won't have Jo1. So these things really are showing very specific associations, which are getting more and more useful. So, okay. I borrowed these slides. I didn't know they did that. Okay. So here we're nearly up to date now. So here's the antibodies which code for the anti-synthetase syndrome, Jo1, ZO, and all the others. And most interestingly, and as I said at the beginning, you can get synthetases whether you've got dermatomyositis or polymyositis. Okay, so they're not specific to either subgroup. Now, anti-SRP, you've already heard me talk about. Anti-SRP is associated with a particularly aggressive polymyositis type disease, which is drug resistant. And a recently described antibody is this one, the anti-200-100, which is the one that you get in statin-induced myopathy. And that also causes a necrotizing myopathy. I haven't had to treat any of these. Lisa, who you heard speaking this morning, she's kind of like the world expert on this. And she says that they do respond to immunotherapy. So the anti-SAE is a newly discovered antibody which types for amyopathic dermatomyositis, which means that patients have dermatomyositis without the muscle disease, or at least at the beginning. This antibody is only detected in the Chinese. And then finally, these antibodies are highly specific for dermatomyositis. Anti-Me2 gives you classic dermatomyositis with periorbital edema, heliotrope, the rash on the back of the hands, but with a good prognosis to treatment. In children, the Me2 antibody, however, codes for skin ulceration. Having Me2 in kids is bad in terms of your skin, but kids don't get cancers. The 155-140 antibody, the 155-140 antibody, in adults, this codes for cancer-associated myositis. Kids, this is one of the most common antibodies in kids, and they don't get malignancies. And finally, this is a more recently described antibody, the anti-NXP or anti-140. This is detectable in kids in high proportion. And these kids are the ones that get calcinosis, the complication which is so feared by the pediatricians. I don't see any kids with myositis. So, and this is just to remind me to say, look, this is the 200, 100. So we come back to this diagram. We need all these mannequins, but you can see now we need lots of other mannequins, because these antibodies are stratifying disease subtypes, which are becoming increasingly useful to people like me to spot disease, what disease could, complications, aggressive disease. And this is a bit of a busy slide, but this is from the Bath group. This is Zoe Betteridge, but she's written this up with Harsha Gunawardena and Neil McHugh. So here we are. Here's the 8 synthetases. This is what the target antigen is. SRP we've talked about. This is the new 200-100 one. Me2 is DM, and you can see that 20% of adults get it. It's rare in children. TIF1 gamma, the 155-140, nearly 30% of kids get this antibody. So it codes for malignancy in adults, but severe skin disease in kids. And these are some of the new ones. So the myositis-associated antibodies, U1RMP associates with mixed connective tissue disease, which I've told you already is associated with a good prognosis. Rho and LAR associate with Sjögren's and lupus. So these are conditions which got a better prognosis than many cases, a better prognosis in respect of clinical phenotype. I don't mean death. And, you know, I've nearly finished now. So this thing has still got way to go yet. This is nearly up to date with the Bath results. In DM, 256 cases, there's 14% of patients we know have got antibodies, but we don't know what they're linked to or associated with. And in polymyositis, nearly a quarter of the patients in the groups tested have got bands which code for something, but we don't know what yet. So I didn't like to say to Chet, but I know of at least 3 new antibodies in this lot. Everything that they can see in Bath, Chet can see in Pittsburgh, but he hasn't got the ability to say what the bands mean. In Bath, they can cut the band out of the gel and send it off for mass spec so they can tell what the antigen target is. Now, in IBM, the biggest study that's been done so far only had 53 patients in it, and they didn't do antibody testing by immunoprecipitation, and it was very superficial genetics. DRBA103 was associated with it, but we desperately need in IBM to correlate genotype with serotype and clinical phenotype to see whether IBM is in the spectrum of PM and DM or whether it isn't. So That's why I said this morning I was so excited that within about a year or two we might have 250 IBMs. So in a year or two I'll be able to tell you whether IBM is or is not part of the PM-DM spectrum. So why bother testing? Well, myositis is clearly heterogeneous. Antibodies are predictive of clinical phenotype, including disease severity, for instance, anti-SRP, which is bad, anti-Me2, which is good, and disease complications, 155, 140 with cancer, JO1, and all the other synthetases with ILD and the potential for heart failure. Myositis-specific antigens are highly specific, so they can help you exclude non-inflammatory diseases such as dystrophies. When you run a muscle clinic, you'll understand that some patients are dead easy. Nothing's easier than a dermatomyositis when it walks through the door because the rash is so characteristic, as they walk through the door. But PM patients often get misdiagnosed, and I work very closely with the neurologists, and Mark Roberts, who's the neurologist, he said that his mean time to diagnosis in his group of patients is 7 years, but he does deal with dystrophies. But in patients with dystrophies, you do get inflammatory cell infiltrates into the muscle, so it can be actually rather difficult. So if you do have a JO1, you can be pretty certain that you're dealing with inflammatory myositis. So antibody results will help plan investigations. So if you're 70 and you've got 155, 140, then you're going to do a very comprehensive cancer search. I had one 155, 140 patient who came in and we didn't know he had this because this was in our batch of waiting to be done sera. But he died about 3 years later from bladder cancer. And we'd done a chest x-ray, we'd done a CT scan of his chest, we'd done abdominal ultrasounds, we'd done tumor markers, and we repeated them every year for 3 years, and he never had any detectable sign of cancer. And then one day, he came in and said he'd passed blood. So we sent off his urine, and it showed malignant cells in it. And when we did a cystoscopy, he had a bladder cancer. And I'm pretty certain that he had his bladder cancer there from the beginning. And if we'd known he had the 155, 140, I would have pushed to examine every orifice. So when I'm 65, if I get dermatomyositis and I've got this antibody, I'll want, if chest x-ray scans, abdominal scans, chest scans are all negative, if the examination's negative, I will want gastroscopy, endoscopy, bronchoscopy, and cystoscopy. Because if you take away the cancer, the myositis gets better as well as the cancer. So, if that gentleman, if we'd known from the outset he had a bladder cancer and we treated it successfully, his myositis would have got better. So he wouldn't have spent 3 years on massive doses of steroids, etc., which so made his life so miserable. Now, and of course, antibody results can also help plan treatment. So if ILD is already present or serologically predicted, i.e. by the presence of an antisynthetase, you would choose not to avoid methotrexate because methotrexate in other conditions, rheumatoid, can cause lung fibrosis. So you wouldn't want to treat someone who's going to get lung fibrosis with a drug that could cause lung fibrosis. And for instance, if someone's got SRP, you'd use very aggressive treatment right from the outset. You wouldn't pussyfoot around with small doses of steroid and then adding in methotrexate and then possibly adding in cyclosporin. You might go for the lot right from the beginning. So now, I've only got 3 slides left now. This is one of the most interesting things for anybody in myositis work now. This is a cell. Now, this is a round cell, but if you pretend it's long and thin, you could pretend it was a myositis cell. These are the internal organelles. This is the nucleus. This is the mitochondria. This is what uses the energy. Here's the endoplasmic reticulum, which helps deal with infection. All of these antigens, which are the targets for the antibodies, are all inside the cell, and some are even inside the nucleus. So how is it that these fragments within the cell could become targets for antibodies? So here's the picture you saw at the beginning. You can see that the T cells are directly attacking the cell membrane. So the immune system shouldn't be able to be seeing inside the cell at all. So it's always been a mystery about how these antibodies are formed or why. Now, here's a cell from an immunological review. Here's a viral cell attacking, here's a virus attacking a cell. Once inside the cell, the virus gets broken down and processed by the nucleus, and then it gets broken down to its constituent parts. And then what happens here, this is the endoplasmic reticulum, and here's the HLA molecules on the inside of the endoplasmic reticulum. And so what happens to these is the cell pushes these to the cell surface. And the reason why it does this is because it wants these viral proteins to be open to the immune system so that it can be attacked. So it's an intriguing possibility that within the muscle cell, when this process happens, it's bringing up with it internal parts of the cell, which then can form antigenic targets on the muscle membrane. So why bother testing for autoantibodies? Well, ultimately, it may even give insights into disease mechanisms. So those are my collaborators. Salford Royal pay me. ARC funded some of this work. Bill Ollier, our geneticist, works here. The Myositis Support Group UK, which is the equivalent of ULOT. It's smaller than ULOT, of course. But they've funded us a lot for this work. The 65 or so AOMIC collaborators, Chet, of course, in Pittsburgh, and these are some of the people that work in Bath. So that's Neil McHugh and Zoe. Lucy is the person who's got the large JDM cohort. Hector works with me. Chet, you know, Ingrid, you know, Jerry, you know, these people are all put samples in. So we'll have the same analysis on about 1,300 cases soon. So we should really be able to say what are, with some authority soon, what are the genetic serotype associations and how strong they are. So I'm going to stop now and take questions if anyone's got them. Thank you. Hang on now, we'll give you the microphone, okay?
I couldn't see the slide very well, but
Right.
the antibodies associated with statin therapy?
Yeah, there is. It's the anti-200, 100 one. It's
Oh, the 200.
Lisa and her lot that discovered that. I mean, that's new in
Is
the
that
last.
available now for testing, or you know?
I don't know the answer to that. I mean, they can detect it in Bath by immunoprecipitation. To make the Bath lab be user-friendly in service terms, what they've done is so hospital trusts from all over the UK can send samples to Bath, but they have to pay for them. So the £165, that's for doing research samples. For us, it's about 300 to do it for service. So you can send them, but I mean, within the States, Chet would be able to detect them because he's got exactly the same immunoprecipitation methods as they had in Bath. So he would be able to detect them. Obviously, this young lady's collaborators can detect them, but I presume it's also by immunoprecipitation. But that's a research tool at the present time because it's so expensive, you see.
Thank you.
So what should you ask your doctor to do? Should you ask them to give you when I go and I talk about these antibodies, how do I get him to check them?
Well, I knew when I was doing this talk, by introducing the genetics, I would potentially cause some confusion, but at the same time, you are a very informed audience, and you can see why, as someone looking at disease mechanisms, I'm trying to bring the two together. But the simple answer to your question is, if your doctor referred you to me in Hope Hospital in Salford, on routine testing, I could only do Joe 1 plus the myositis-associated antibodies that I showed you. But I could then send the sample to Bath if I had a high index of suspicion. So if someone comes with, let's say you were 70-year-old and a man, and you got dermatomyositis, and you had no routine antibodies, I would be suspicious that you could have cancer-associated myositis. So if I then did chest X-ray, chest scan, abdominal scans, tumor markers for prostate cancer, etc., and they're all negative, I wouldn't necessarily then want to go and do bronchoscopy, endoscopies, cystoscopies. But if I sent your sample off to Bath and 3 months later the result came back and it was positive, then I would call you back and I would want to give you the option of saying, look, do you want all these other tests? Because if it was me, I would want the tests. So the 155, 140 antibodies are crucial. And I think the Spanish have done, they've used the same methods as everybody else. I'm not quite sure how they've managed to make it work when nobody else can. But it's going to be crucial to be able to detect 150, 140 on a routine basis. And the line blot testing, the one in the middle, the company that run that, it's a German company, if they could make the 155, 140 antigen target so that they could get the antibody to stick to it, they would then have a viable routine method of testing for this antibody. So this is the really crucial one. But you can understand, if somebody is likely to get interstitial lung disease, you wouldn't want to give them methotrexate. And for no rheumatologist in the UK is that information available, you see. And I think it's the same in the States. So I think your routine laboratories test for the same as ours. So Chet does his antibody testing by immunoprecipitation for research purposes, you see. I mean, he may test his own patients, but he doesn't test everybody else's.
So when we went to our doctor and talked about the enzymes, there's no way that he could find out what ones we have.
Well, what he'd have to do is refer you to a specialist myositis clinic, I think, and then, and I presume, there's now 6 specialised myositis clinics in the UK, and they are all sending their patients blood to Bath if they've got a high index of suspicion, but they're all paying £300 a time for the benefit. But I mean, money shouldn't be an issue, should it really?
I do have one more question. You
Okay.
talked about right heart involvement. Do you
Yep.
mean the right side of the heart?
Yeah.
Because I have a cardiomyopathy on the right side of the heart after.
Okay. I set up my tertiary clinic 12 years ago, so I've been seeing myositis patients on a weekly basis. But because the way I've come into muscle is from doing muscle physiology, so I've been around myositis patients for a long time. In 20 years, I've never seen anybody go into left heart failure. I've never seen anybody present with congestive cardiac failure due to left heart failure. So the notion that myositis could affect the left ventricle is not really been investigated properly, but in clinical terms and practical terms on a day-to-day basis, it's not common. Right heart failure occurs because if you've got severe pulmonary fibrosis, your blood oxygen in the lungs falls, and that makes the blood vessels go into spasm. So the blood pressure in the right side of your heart goes up. So it should be about 20, 25, and some patients it'll be 50 or 55, you see. So the right ventricle was never meant by design to be able to take the same pressures that the left ventricle can take. So the right heart eventually just fails, so you go into right heart failure. And when you go into right heart failure, blood doesn't get pushed through the lungs. So I've seen 2 people die precipitously. I mean, they look as though they've just had a pulmonary embolus. They just go completely cyanose and go unconscious. It's horrible. All right. Oh, okay. Well, I mean, with treatment, I mean, if you stabilise the interstitial lung disease so that the right heart pressure doesn't go up and your right heart can tolerate the pressure, that's fine. And you can do things to dilate the pulmonary vessels nowadays. So obviously, sclerodermas get pulmonary hypertension as well, and there's very expensive but very effective treatments now to bring down the pressure in the right side of the heart. So that's less of a problem these days.
Hi, I'm here. I came here with my aunt who has IBM,
Okay.
so we could learn all we could about this. As I'm here, I think I've learned a lot, but I have a lot of questions now about a genetic family type thing because she has IBM.
Yep.
My father died with Parkinson's. I have 3 aunts who have fibromyalgia, 1 aunt who died of leukemia, 1 uncle who died of cancer. These are all brothers and sisters. 1 of their children has now multiple sclerosis. And 2 years ago, I was treated for cancer. And then in the last several months, I noticed in my yoga class that I'm losing my strength and was off balance, who I've seen a neurologist who was really checking to see if I had cancer spread to the brain, but it didn't. And then I started a lot of aching and myalgias. And so I stopped my cholesterol med, and my doctor agreed with me. Is there some connection here? Could there be some connection here in a genetic thing?
Well, the only 2 things that are autoimmune definitely, well, I say definitely, multiple sclerosis is an autoimmune disorder, and where they've done genome-wide association studies in rheumatoid, which is common, in diabetes, which is common, HLA, it forms a very big susceptibility peak in all of those diseases, but there's about 30 other genes which are there to a greater or lesser extent in all those other diseases, and they're called the pan-autoimmunity genes. So we know that lots of genes in these autoimmune conditions are linked. What we don't know is what they do to sort of promote the disease. So multiple sclerosis is accepted as an autoimmune disease. If you consider that in statin-induced myopathy you do get antibodies, well, statin-induced myopathy is a quasi-autoimmune disease, isn't it? It's just that to show whether those pan-autoimmunity genes were also overrepresented in statin-induced myopathy, you need 1,000 cases, you see. So all of the other things that you've talked about aren't autoimmune, so the others are all by chance, really. So if you consider statin-induced disease as an autoimmune, or quasi-autoimmune, then those three things could be linked, but the cancers won't be linked to autoimmunity. The cancers may be linked genetically, but not through autoimmunity. Does that answer your question? So there's who's got the microphone?
I do. I have a question.
Okay.
A couple of questions about Joe 1. I understand is when you have one MSA, you can't get another. You don't have another one. You only have one. That's correct? Isn't that?
You can.
I mean, you can have an MAA.
We've looked this up, and there's 2 case reports of people having more than one
really?
myositis specific, but in both of them it was a Joe 1 with another synthetase.
Oh.
So I would be being speculative if I said all of the anti-synthetases will all be linked to the haplotype 352, because we haven't done that analysis yet, and because we've got small numbers, I don't think we would have a meaningful answer. So what I think, when we've done the 1,300 cases, I think what we'll be able to show is that all the synthetases will all be linked to 352. So that last cell I showed you where the HLA gets taken up to the cell surface, what it means, you see, what it means is if you're 352, so something upstream of the endoplasmic reticulum is making this thing happen. So something's driving it, we just don't know what it is.
Okay.
But whatever it is comes along and it drives the process of upregulating HLA to the surface. That takes fragments of the cell inside of the cell to the surface, which then gets recognized by the immune system. So if you're 352, the bits that you take to the surface will promote the generation of an antisynthetase. If you're 722, the bits that by chance get taken to the cell surface promote the promotion of anti-Jo1 antibodies. So to me, it seems as though if you get myositis, whatever the stimulus to get myositis is, you're kind of predestined to get one antibody or the other. And I've asked Raju before, you see, his mouse model always uses the same genetic strain of mouse, and his mouse model does generate anti-synthetase antibodies. And I said to him, if you generated the same process in a different mouse model, would you get different antibodies? I've asked him that, and he said that's very interesting, but he just hasn't got around to doing it. You can see how busy he is.
My other question about Joe 1 is, I was originally, I was told I was positive, but was not given, I have to use the word concentration because I'm not a medical person. I was told no concentration. In fact, the doctor said he did not know that. My question is, do I need to know, is it the titers? Is that the correct term? And do I need to be tested more than once for Joe 1?
Okay, that's a very interesting comment and question. Our lab, it's an ELISA, so it's
ELISA, yes.
Yeah. So
mine wasn't done with ELISA.
So it just shows you. I mean, ELISA could give you, if you've got Joe1 positive anti-synthetase syndrome, you'll always have Joe.
Right.
But Fred Miller has shown that he had a family with ultimately two patients with Joe1 positive disease, and he spotted the first one, and he immediately took blood from the twin or sibling, whichever it was, and this twin or sibling also had anti-Jo1 present in the blood, and had it present for years before they then also got myositis. So he was able to get titers. ELISA can give you titers, but it's much more expensive, so the labs tend not to do it, you see. And if you are Joe1 positive, you tend to stay Joe1 positive. But what Fred shows the sibling who ultimately did get polymyositis, her Jo1 titer went up and up and up until eventually she got the disease. So if you suppress the process, then you would speculate that the titer would come down. But I mean, I haven't got any proof that that's the case.
Okay, so what you're saying is I don't need to worry about being tested again?
No.
Okay, thank you.
I have DM, and I'm wondering if I should know what antibodies, if any, or what MSA antibodies I have. I'm sort of, I won't say concerned, but I'm wondering if my antibodies show that I'm a risk for cancer, then I'm wondering if I should be on drugs that have a known cancer risk, even though I know that the risk is low.
Okay, what the gentleman's asked me really is, he's got dermatomyositis, and he wants to know potentially what his cancer risk is. In other words, has he got 155, 140? He didn't say that, but that's what you meant, I think, isn't it?
Yeah.
Well, the answer is, how old are you?
I was diagnosed 4 years ago when I was 42.
42. Probably you're unlikely to have it. You know, it's in the group. I mean, we've only got 16 analysed to date, but sort of the mean age was about 72. So you're in a much younger age group. So the ones in the non-CAM group, the 11 155, 140 positive patients in the non-CAM group were all less than about 50. So probably you're not at a risk. But I mean, you know, your attending doctor could send blood to Chet, and Chet could tell him whether you've got it or not. He would just have to pay for it.
Well, and I think part of the issue is he goes in for endoscopies, he goes in for colonoscopies, he goes in for the testing periodically, and it just seems like, well, couldn't one test just tell us if that's going to be in the future rather than going every 2 years?
Well, it only gives you, it allows you to predict the odds, doesn't it, really? You could still get CAM and be 155, 140 negative, but the statistics show that's really very unlikely. So knowing 155, 140 would help you say, look, it would give you the ability to say, I don't want any more sort of tubes, any more orifices, wouldn't it, really? I mean, so, I mean, the 155, 140, it's crucial that somebody makes a good, cheap, routine test, because it'll be the one antibody that really transforms how we all work. I mean, you know, if somebody, as I say, if I get to 65 and then get dermatomyositis, and I know I've got 155, 140, and all the routine cancer screens negative, I'll want the lot. I will. But if it's negative and I was 35, I'd say, don't want any tubes, doctor, thank you very much. You know, because, you know, they're invasive tests, aren't they? Yeah. And you know, there isn't any way that the whole thing is guided. So, I mean, some physicians will fastidiously do all the tests at presentation at year 1, at year 2, and at year 3. So it's expensive. It's a massive amount of time out of work, isn't it, to come in and out for hospital testing, etc. And it's unpleasant, you know, tubes up the rear end ain't much fun, is it, really? Does that answer your question? I think there was one over here, wasn't there?
I have JO1. I've been on Plaquenil for about 16 years. I try and take breaks from it as often as I can, like to try and get a month or 2 off, but I'll get sick and I'll go into a flare and I'll have to go back on it. Is that going to increase? Like, I know I'm JO1, you said does not have cancer, but will that increase my risk of cancer? And should I be on this drug that long?
Okay, the question that the lady's asking is, she's had Jo1 for 16 years.
26 years.
26 years, I beg your pardon. And she's been on Plaquenil for most of that time, and she keeps having time off the Plaquenil. And she's really asking, you know, should she continue the drug? I mean, Plaquenil's pretty you know, I mean, Plaquenil is not a, in the doses that we use it in rheumatology, I mean, in 35 years, I've never known anybody get macular problems. The people who got macular problems were soldiers in the war who were taking like about 5 grams a day, every day for 5 years. So, you know, we give it 200 or 400 a day. And, I mean, the only thing that my patients ever complain of is nausea at the beginning. Once they're settled on it, they seem settled. So So, I mean, if you were my patient, I'd say, well, why do you want to come off it for spells? Why not just stay on it? Oh, I see. You mean from the hydroxychloroquine, you mean? Okay. This gentleman alluded to as well before, and I didn't pick up on it. If you look at a much more common condition, rheumatoid if you've got rheumatoid, you've got an increased likelihood over your lifetime of having lymphoma. Now, we don't really know whether that's just because of the disease activation of the immune system, driving the immune system very, very hard, or whether it's due to the immunosuppression. We do know that if you take azathioprine or methotrexate, your chances of getting lymphoma go up even higher, you see. So azathioprine and methotrexate could probably represent, increased risk of lymphomas down the line, but hydroxychloroquine doesn't carry any cancer risk with it, as far as I know. Good.
Hi.
Sorry,
I don't know.
yep.
Excuse me, I went to the restroom, but I wondered with the antibodies in terms of the connection with IBM. My husband was diagnosed with it in January.
Okay.
And
Yeah, I did. When I've given similar talks to the UK Myositis support group, I give a talk which I think is great, and then somebody puts a hand up there and says, what about IBM? And the reason why I don't go on about IBM normally is because I've only seen about 3 cases in my whole myositis career. But I am seeing more cases now that I work together with Mark Roberts, the neurologist. But I did go to pains, and I did notice that you had to go out. The biggest study that's looked at the genetics or antibodies in IBM only had 53 patients in it. So some of you know, I mean, I put up beautiful pictures of classic IBM with finger flexor weakness. But there is another phenotype in IBM. It's the one that presents with quadriceps weakness, which looks exactly like it must be polymyositis. And you do the biopsy and you don't get classic IBM changes. So you give it the label polymyositis, and then nothing works. Same as nothing works for IBM. So you're 2 years down the line, you've had high-dose steroids, you've added in methotrexate, you've added in cyclosporine, you may have given them rituximab, you may have given them IVIG, and they still haven't responded. So you think, well, what's going on here? And then you biopsy them again, and they may still have inflammatory cells, but if there aren't any specific changes to confirm IBM, and there's no characteristic finger flexor weakness, then you just call them drug-resistant polymyositis. So that's why some of these cases go years before you get a true diagnosis of IBM. So that group of patients spend a long time getting to the final diagnosis. And once they get to the point where they have got finger flex weakness, I mean, that might be years down the line, you see. So that's just a misdiagnosis, and you've done everything that you could do to try and get a positive diagnosis. I mean, there isn't a blood test for IBM. You're reliant upon the biopsy. So if the biopsy doesn't show it, so in that particular subset of IBM patients, you're left having to repeat the biopsy. And I normally do closed biopsy using what's called a conchytome forceps. But Mark Roberts, he gets, I get sort of the bottom of the barrel patients who haven't responded to anything. People send me those patients. But, when I struggle even, I send them to him. So he gets even more bottom of the barrel than me. And he just says, look, what we need is a big open biopsy. So he gets the neurosurgeons to go and do a whacking great big muscle biopsy so that histologists can take multiple samples all the way along the sample. And then if you go to that sort of trouble, and then you do start picking up the IBM. So the IBM in the patients who present with quadriceps weakness at the beginning, they may go 5 or 6 years and have 3 or 4 biopsies before you get the diagnosis. So in the same way that antibodies and genes split up polymyositis, dermatomyositis cases, does the classic forearm finger flexor patient have the same genes as the one that masquerades as a polymyositis? And the fact the answer is we don't know yet, you see. That's why it's very, very important that we do with IBM what we've done with DM and PM, because, either IBM is in the same disease spectrum or it isn't. My own view is that it's a different disease. But that study of 53 patients did have 2 or 3 patients with JO1, and they did find, that DRB103 was significantly associated. So the genes are a little bit same, but I tried to show you with the DP that, you know, these genes around class 2 interact. So it may be that DR3 with another gene acts in a way to make a slightly different disease. Yeah. Yeah, okay. What the lady's asking is, is anybody else trying to do the same? Well, the answer is probably. The reason why I'm doing genes is because I work in Manchester with Bill Ollier. Bill Ollier is an international expert in genetic work, but he doesn't see any patients, of course. I do 4 clinics a week, including 1 myositis clinic, and I do general medicine, so I'm rushed off my feet. But I can at least put in effort to get blood samples to him. But the most important thing of all is the clinical phenotype. So it's the clinical details which make this quality work or not quality work, you see. So I don't see IBM patients often, but now I've started this collaboration with Dr. Roberts, my neurological colleague. He's introduced me to Professor Mike Hanna from Queen Square, London, and he's an international expert in clinical IBM. But of course, he wasn't doing any work on it. I mean, he wasn't doing any genetics or even, you know, neurologists don't know about these antibodies, you see, in general terms. So there wouldn't be any stimulus to drive him to do it. But now that we've got the genetics working so well, and we've got 50 cases, the Newcastle neurologists have sent us nearly 100. So it'll be a way of twisting Mike Hanna's arm and saying, look, Mike, send your 100 up, for goodness sake, because we want to get on and do this. Because every time I come to a meeting like this, the IBM patients all say, well, what about IBM? And it isn't because I'm ignoring it. It's just that until I get the samples, I can't make it happen, you see.
Hello,
Where are we?
Dr. Cooper.
Oh, sorry.
You mentioned a complex of symptoms, Raynaud's, destructive arthritis, and ILD. Was that it? The complex that you talked about, and then you,
the Anti-Synthetase Syndrome, yes.
And I was wondering, what destructive arthritis is that? Rheumatoid, or could that be osteo?
Okay. What the ladies asked is, I've described Anti-Synthetase Syndrome, and I've said that you get a destructive arthritis as part of the Anti-Synthetase Syndrome. And any inflammatory condition, any autoimmune condition which involves inflammation could by chance give inflammation in joints. So sometimes patients with vasculitis will get painful joints. Sometimes patients with lupus will get painful joints. But in most conditions other than rheumatoid and the rheumatoid spectrum, most patients don't get any damage or destruction to the joint. With Anti-Synthetase Syndrome, it can actually cause inflammation in the joints sufficiently severe to give you destruction or damage to the cartilage. So it can mimic rheumatoid. And as I say, I've got about 3 patients who were treated for more than 2 or 3 years each for rheumatoid, and then they developed what was thought to be rheumatoid lung. But of course, they had Anti-Synthetase Syndrome all the time. And they were treated as though they got rheumatoid because they got erosions.
And were the 2 antibodies that you offered with that syndrome anti-ZO and PMSCL? Is that what you
Yeah, the case that I put up was somebody who presented with symptoms and signs and radiographic changes in keeping with interstitial lung disease. And they were thought by the chest physicians to have idiopathic pulmonary fibrosis. And it was only when the junior doctor, well, relatively senior junior doctor, sent off blood for the antibodies that they realized that actually it was an anti-synthetase all the time. So, and it just so happens that that was an anti-ZO, and ZO is just one of the 8 anti-synthetases. So it's a bit confusing because there's so many. But I mean, most UK rheumatologists don't know that there's 8 synthetases. So you lot are all more well informed than that.
Your slides, can we have a copy of your slides, like on the website, or are you going to be?
Somebody else has asked me about that. I mean, if on the contact list, you got my email. I mean, if you want me to send you slides, I'm quite happy to do that.
Thank you.
There's one other question here. Here.
One more question on Joe 1. It's also listed as having fever. Is that intermittent, constant, low grade, high, what?
Okay, that's a very interesting question. It's usually presentation. In other words, before you start treatment. Once you start treatment, that aspect normally settles. There's something peculiar about Anti-Synthetase Syndrome in that over the years, I keep meaning to do this, but I've never got around to it because I have to keep driving all my energies to make people send me their bloods. But it's well recognized, you know, the majority of patients with dermatomyositis and polymyositis don't get raised ESR, you know, sedation rates, or raised CRPs. In other words, they don't seem to get an acute phase response. So, you know, so if you know, muscle comprises 40 to 50% of your body mass, and if all the muscle in your body was inflamed, you would say, well, how can it be that you don't get an increased sedimentation rate? How can it be that you don't get a raised CRP? And the answer is I don't know. But in anti-synthetase syndrome, there's a very selective elevation of ferritin. Ferritin is another one of the acute phase proteins. So in patients with ILD, they are getting a systemic part of their disease, which many other myositis patients don't get. So in those patients, you know, they would have elevated ESR and CRP. I've forgotten what your question was now, sorry.
Fever. It's all
Oh, fever.
always listed with fever.
So patients with interstitial lung disease, ILD, they are having a very obvious acute phase response. So if you have an acute phase response which is high enough in any disease, so gout, rheumatoid, lupus, etc., you can have swinging temperatures. It's just because of the level of the acute phase response. That's what it is.
Okay.
At age 31, during my third trimester, I became, I guess, symptomatic, but I wasn't diagnosed until 1 month postpartum. And I did test positive for the anti-Jo1. I'm currently on methotrexate, prednisone, azathioprine, and I've been dosed a rituximab treatment. I would like to, I guess, after hearing that, throw my methotrexate away, but what is the recommended adjunct treatment? And also about, like, how do I go about monitoring CT scan, X-ray?
Okay. What this lady's asked, just in case you haven't heard, is she's got Jo1 diagnosed in the third trimester, and she's been put onto prednisolone, and she's also been on methotrexate, azathioprine, and I've said to you that if you had an antisynthetase, it wouldn't be logical to go on to methotrexate, because in other conditions, such as rheumatoid, methotrexate is said to cause lung fibrosis. That latter statement isn't particularly well established. I'm only playing it safe. If I knew you had a synthetase, I would choose not to put you onto methotrexate, just in case. Nobody's done the study to look at methotrexate and Jo1 and not methotrexate and Jo1 to show whether methotrexate is likely to cause pulmonary fibrosis. But I wouldn't want to take the risk with you, you see. So I would, if I knew you had a synthetase, I'd put you on azathioprine instead, you see. Because you can always add other things like cyclosporin or mycophenolate. You don't have to use methotrexate. I mean, there's been no head-to-head of methotrexate versus azathioprine, methotrexate versus cyclosporin, methotrexate versus mycophenolate. So there's no documentation that one's better than the other. And there's no proof that methotrexate does cause pulmonary fibrosis. But if I knew you had Jo1, I would choose not to put you on methotrexate, just in case that, you know, it would cause methotrexate lung, you see. Are we all done? Any more? Okay, thank you very much. Okay. Listen, can I ask you a question? I've given a similar talk to this to the Myositis Support Group UK, and I was terrified because of the intricacies of the genetics and things that they would be totally bored and not see the relevance of it. But they all weren't bored, and they all did see the relevance of it. And I mean, that wasn't too. Go on.
I would say that for me, the first half seemed a lot like chemistry. Thank you. But around the time that you started showing the mannequins,
Yeah.
then it started making sense.
Okay.
And then I could start thinking about how he presented, and it all started kind of going that way then.
I suppose from my own point of view, I mean, I'm interested in the mechanisms, you see. And if it's true that your antibody production is predestined by your HLA class 2 haplotype, I think that's pretty important. And that's why I said to you earlier on in the day, if you haven't had genes and serum taken for research, you should pester your surgeon. So, because he could send that off to Fred Miller, you see. I mean, no point sending it to me. Fred would be distressed if you sent it to me. But get your base consultant to send it to Fred Miller, because he's trying to do the same with US patients as I'm doing in the UK and Europe. I mean, I spent the last 12 years of my life driving my colleagues to recruit patients for me. I mean, they don't get anything out of it. I buy my pint at the BSR and things like that. But I mean, research is hard, and getting ethical, so I've had to get ethical permission at 64 different sites, you see, and some of them only got 2 patients. So it's a real big, getting ethics these days, it's enormously time consuming. But unless you do this groundwork, so when I said this morning we'd started looking at genes outside of HLA with the genome-wide association study, we put, with the Europeans, that's us, Ingrid, Katalin Danko, Jerry, and one other group, we put in 650 DM patients, including JDMs, and the Americans under Fred put in, so we had about 1,100 DM patients, the biggest group of DM patients ever assembled for genetics, and it didn't show anything except HLA. So after 12 years grinding away, costing people money, I mean, the Myositis Support Group UK is much smaller than you, but they gave me 90,000. And when you do genome-wide associations studies, each chip costs $350. So you're talking vast sums of money, really, to do this type of research. So that's why it's been so hard just to get this far, you see. And so after 12 years, and Peter Gregerson said, you need another 2,000 patients, I ain't going to be alive long enough. So that's why I say, you lot need to drive the process a little bit yourself. I mean, your base consultant should be willing to send blood to Fred in clinical details, because unless he does, you're not going to make any progress in research terms. So what Peter Gregerson did show was that the pan-autoimmunity genes are upregulated in DM. So in common conditions like rheumatoid, when they understand what the pan-autoimmunity genes mean, then you'll be able to apply that to dermatomyositis. So if you like, we'll have a running start in terms of what the overall genetics mean, even if we don't find any other genome-wide significant results. No, so we're going to be looking in an analogous fashion, really, aren't we? So we're going to be taking what they know from rheumatoid, diabetes, etc., and applying that to dermatomyositis and polymyositis. We haven't even done a genome-wide scan on polymyositis yet, because we haven't got enough samples. So we've got nearly 1,200 samples in total in Europe now. I mean, that's massive, but that's 12 years' work, really. So that's 100 a year for 12 years.
So I had a simple question. So when I go to my rheumatologist and I want to give blood to Fred Miller, what should I be telling my rheumatologist? Just do a simple blood draw?
Well, what your rheumatologist could do. Where do you live?
I live in Colorado, just south of Denver.
How far is that from NIH?
About middle of the country.
Yeah,
and
okay. Yeah, that's the problem, isn't it? I have to say, in Czechoslovakia, where Jerry is, he sees the myositis for the whole country. I went to see him. He's got patients who come 500 miles round trip in a day just to see him, because he's the only one doing anything. So for your GP to take, or for your rheumatologist to take blood for research purposes, I presume he would have to have ethical permission. And for him to get ethical permission will take him a lot of time, and of course it'll be his time and somebody else's study. So he may or may not be willing to do it, you see. That's the problem. So, I mean, he could send you to Fred and say, look, Fred, here's another one. you know, here's all the details. So Fred can fill in all the paperwork. So he'd see it, he'd confirm it, he'd take the blood for serum and for DNA, and then you could be in the study. So it's kind of up to you whether you'd be willing to give that much time and money to get your blood into the sample, into the cohort, really. You know, so it's kind of, you know, it's tough. I think the lady in green was first.
I was going to say, it was technical, but I think we kind of expect that, some of us. And even though it might be a little bit more in-depth and kind of overwhelming, at the same time, you get the picture of it, and if you really need more questions, I think we can ask. How many of you guys felt that it was too difficult? See, we're fine.
Okay, good.
Yeah.
As a teacher, I thought you'd like that.
Yeah, that's great, thank you.
I just want to ask one question I was shy to ask before, but it's important. I was diagnosed with PM, and I'm on methotrexate, folic acid, and 30 milligrams of prednisone. Now, I do a blood test every other month, and I know my CPK is important to him. Now, could you repeat the test, the three important tests that is suggested for the PM?
And this lady's got polymyositis, and she has regular blood tests. That's for drug monitoring, I presume.
Yeah, for the prednisone, I guess for the prednisone and the methotrexate.
What's the other one?
Methotrexate,
Oh, methotrexate,
and folic
yeah.
acid.
Yeah, okay. If you're on methotrexate can suppress your bone marrow, and it can also upset your liver. So if you go on to methotrexate, if it's going to do it, it normally does it at the beginning. So you start at low levels and work it up, and during that time you get regular blood tests to try and detect whether there is any problems with the liver or the bone marrow. If there is problems with the liver or the bone marrow, you would have to either reduce the dose or back off and use something else. So you do have to have regular blood tests. It's called monitoring, and it's the same for rheumatoid, psoriatic arthritis, and we always use it. We monitor monthly, but that's the British BSR guidelines for rheumatoid. So we just follow those guidelines. So CK is, in some patients, CK is a fantastic way of assessing disease. So the CK might be 2,000 when you first present. You go into treatment and the CK will drop, and then as the CK drops and you feel stronger again, then obviously your physician would back off with some of the treatments, because obviously he'd want you on the minimum doses of everything that did the job for you. So let's say you got the prednisolone down to 7.5 milligrams, fine for 2 or 3 months, and then all your symptoms come back and your CK shoots up again. For an individual patient, that you say, look, the disease is active again, and for that patient, CK is a great way of assessing disease activity. But one of my worst patients who presented with dysphagia, she's got rampant myositis on her MRI scan and rampant myositis in the muscle biopsy, but her CK's never been up. So CK isn't just a very good measure. In terms of antibodies, with immunoprecipitation, it's an all or nothing. It's not like an ELISA. An ELISA, you can make an ELISA more and more sensitive. So you can detect antibodies at progressively lower concentrations of the reagents. But with immunoprecipitation, it's the antibody's either there or it's not there, you see. So there isn't any quantification for immunoprecipitation. Does that answer your question?
And maybe you spoke to this, along with looking at antibodies, are you also, in terms of the women up front, looking at family histories?
Yeah.
And in terms of seeing histories, which is true in my husband's case, of a lot of autoimmune disease, scleroderma, sarcoid, lupus.
Okay. This lady's asking about family history. One of the difficulties, I know you had to go out, and I wasn't sure whether you were there when I showed you that slide, but if you want to know how heritable a disease is, you have to work out what's called the lambda S value. And the way that you do that is you look at family members and see how many others of them have got the same genes. Now, I'm not a technical geneticist, so I don't know how to work the lambda S hat out. But because myositis is so rare, no one's ever got round to working out a lambda S. Because, you know, if it's hard enough to get patients' blood from all over the UK, which, you know, the UK is only 800 miles from start to finish, so if it's hard enough in the UK, it must be much harder if you've got the Grand Canyon between you and the rest of America. I forgot what you said now. Oh, families. Okay, so you know, if I'm getting blood from a DM patient in Glasgow, I've not only got to get the patient encouraged to give his blood, I've got to get his consultant encouraged not only to take the blood, but to get ethical approval. And I don't know about the US, but ethical applications in England now, well, they're not quite as thick as 8 inches, as per what you saw already. But I mean, the effort to get one single site onto a positive ethical application, it's huge. So I've got somebody called Mr. Paul New. He works he's a full-time research associate, and he spends all of his time just driving the process of getting ethics on all these sites. And if you want to get a new site opened up, it's a nightmare. And every now and again, you see, the ethical application I originally put in was 1998, but they've changed the process of ethics numerous times since then. Every time they put in another process, it's another hurdle. You have to apply it again for the same 60 sites. So it's almost like painting, you know, the bridge at San Francisco. You know, you just get all the sites back on board, and then they change the rules again. So it's a nightmare, and you know, I am bloody-minded and determined, but I have to spend hours and hours of my own time and working with Paul New to keep this show ticking along, you see. And we're up to 750 now. But you see, finding all these antibodies and finding all these subtypes may be great for patients, and it may be great for clinicians, but it's a nightmare for genetic statistics because, of course, every time you get a new subgroup, it weakens your statistical power. So if you want to do a genome-wide association scan, somebody might turn around and say, well, we only want you to do it on anti-Jo1 patients because, you know, it's such an obvious group to do it on, or anti-synthetase patients if we know they're all genetically the same in due course. But, you know, you're going to have only a few hundred patients in the whole world if you do that. That's the problem. So in a way, we've been victims of our own success by finding all this interesting information about antibody subtypes and therefore clinical subtypes. We've kind of made it much more difficult to do proper genetics because nobody thinks we've got enough power.
First, I want to say thank you so much. You solved so many issues that I had or questions. The next thing I wanted to mention, because on the myositis.org site, we're always discussing what could have caused this. A factor that came up that I questioned, and then a number of others mentioned it also. My mother kept having her periods during her pregnancy, and she was given a drug to stop her pregnancy. There was another person, I can't remember who, said also they were giving this injection, and another woman took it herself. So I just thought I'd bring that up in case it is a factor. Okay.
What this lady just highlighted is etiology. I mean, I could have put another 20 minutes on etiology, couldn't I? And obviously, viral infections could trigger this disease. But as we get, you see, when your immune system meets a virus, it has a very specific reaction to it. It's the immune system has got the ability to have lots of different facets because you only want the antibodies to stick to that one new pathogen to get rid of it. You don't want antibodies to stick to everything because they destroy everything, you see. So that's what immunological specificity means, you see. And if you think about it, because there are so many antibodies, you know, each antibody will detect a different thing, you see. And it'll be specific to something. But you see, if you've got 18 different myositis-specific antibodies, they can't all be initiated by the same virus, can they? Because of the issue of specificity, they just can't be. So, and the other thing is that in the terms of cancer-associated myositis, you know, each cancer cell type will have a very specific protein, sort of, it'll look from the outside very specific. So an antibody may latch on to a prostatic cancer cell, but the same antibody won't latch onto a breast cancer cell. So because there's lots of different cell types can produce cancer-associated myositis, and because there are so many antibodies present, MSAs, you know, one virus can't be causing all that, and because the cancer types are all different, the cancer phenotypes are different, so they can't be causing the same antibody. It's just too fanciful.
You know, what struck me on this one was that one of the women who took the drug during her pregnancy also has JO1 antibodies. So it struck me we had a common thing, and I know my sister has always said, I wonder if the reason you're sick is because mom had to take that drug to keep you in her body. Now with statins, they've discovered causing myositis. It was kind of well, maybe some sort of a drug given to my mother while I was in the womb could have done this.
Well, what the lady is saying is, could drugs, including statins, induce... statins don't induce JO1 positivity. Statins produce a different antibody profile. And indeed, you know, if you stop the statins, in most people, I was a bit surprised when this young lady published her first paper on, you know, anti-200-100 by saying it was an aggressive necrotizing myopathy which needed treatment. In those cases of statin-induced myopathy that I've been involved with, if you stop the statin, it just gets better. I mean, I wouldn't treat a statin-induced myopathy unless I thought it wasn't a statin-induced myopathy. I'd just wait, because they usually get better. They can take months and months and months to get better, but they do get better. So, any more for any more?
Yeah, I have a question here.
Okay, sorry.
Yeah, forgive me for, I'm a first-time attendee, so a lot of this stuff seems awfully complicated. But I have IBM. I was diagnosed in 2007, and I also have a rash on my back. We can't figure out what it is, and I have a concern that maybe it might be something related to dermomyositis. But my main question is, I keep hearing that the immune system is involved in this disease, and I don't know, where is the immune system at? I mean, how would we know more about our immune system? Is it located anywhere in the body, or how? Can you give a simple explanation of where the immune system is and how we can deal with it, or know more about it?
Yep, the immune cells are derived from the bone marrow, and there's T cells and B cells. T cells are things which kill antigens within tissues. B cells make antibodies which have an which regulate the immune system in a different way. So they all pass through things called lymph nodes, and in the lymph nodes they get altered to change their reactivity. So ultimately it's in the bone marrow, and when you want it, one of the things which people have tried for difficult myositis is autologous bone marrow transplantation. So what you do is you give somebody near lethal doses of cyclophosphamide. Patients would die if you didn't support them. So for 3 days their bone marrow's got no cells in it at all, but you've already harvested their bone marrow and you've separated out the stem cells. And then what you do on the 3rd day, when the cyclosporin's all gone, so that what you don't want to do is put your stem cells back in where the cyclophosphamide would just kill the stem cells. So you put the stem cells back in on day 3 and they repopulate the bone marrow, and then your immune system starts up again. And of course the hope is that when it starts up, that the bad cells don't come back, and it does seem to work, but eventually the bad cells do come back. So
well, when I first found out I had the IBM, I went to a rheumatologist and I said, well, seeing as this is an autoimmune dysfunction, maybe I should just try to build up my immune system. And my ignorance, supposedly. I was thinking just take vitamins and all kinds of healthy food and so forth. And he said, oh no, you don't want to improve your immune system, things will just get worse. Could you comment on that?
Yeah, what the gentleman's asked is he wants to boost his immune system and in a situation where he's got an autoimmune disease. The treatments that we use to treat myositis suppress the immune system. I mean, that's what they're designed to do. So when you get a new myositis case, you do an MRI scan and it's full of edema, which is the white stuff I showed you on the picture. And when you successfully treat it, the cells disappear or become substantially less in number. The edema on the MRI scan settles. So by suppressing your immune system, you've taken away the cells. Now the cells are the things which are mediating the damage, but weakness in the absence of inflammatory cells is being increasingly recognized as a problem. So it's not just about the immune cells, that there's more to it than that.
So the average person could not really do anything
No.
to improve the situation?
No, you can't. Well, I'm not an immunologist, but I wouldn't know how to alter my immune system other than to suppress it.
I hear a lot of talk from people talking about naturopathy, you know, using vitamins and eating certain kinds of food.
But I mean, if you're eating a normal diet, you're getting plenty of vitamins, aren't you?
All right, thank you.
I think that lady was first.
Hi, I'm Joyce Olson. I had immune disorder, 1989. The head hematologist at Scripps was a scientist. He was doing research with, well, anyway, I had 3 bone marrow tests done, and they said I had, my bone marrow was attacking itself. It was an autoimmune disorder. And the only thing that was an alternative to me dying was to have a bone marrow transplant or to try me on Danacrine or Danazol, which was an what do you call it, a steroid. It's anabolic steroid.
Oh, right, okay, yep.
And I did respond to the anabolic steroid, and the doctor said that I was lucky. I was his second patient. And the first patient that he had that had aplastic anemia, he let her stay on the drug because she asked him if she could just stay on it, and she was going to die anyway. Why should she not take it to try it for longer? And they were giving the drug for 1 month, and he said that it takes 3 months before the drug effectively builds up anything. So I am responding, and I did fine, and he took me off the drug after 6 years. He weaned me down to nothing. And I was off of it for 11 years, and now with IBM that I was diagnosed with 5 years ago, I thought about all of those documents that I had from Dr. McMillan and Scripps. And I thought, gee, I remember how my muscles felt. They were so good. I was able to walk 3 miles up in the desert to the wind tunnels, and I never hadn't been able to do that before.
Well, what this lady's talking about is stanozolol, which is an anabolic steroid. I mean, anabolic steroids make you grow muscle. Well, they make you grow muscle. I mean, that's why.
Well,
that's why
they stopped my attack of my bone marrow.
Well,
and they built up my blood.
That's not my area, but
well,
but we know that they make you grow muscle because it makes you get disqualified from the Olympics.
Yeah, but is there some reason that the doctors don't put the people on a steroid that is going to stop this fight in the body? Because I started 4 years ago to take this drug again. But my rheumatologist didn't know how much to give, and I did not want to take 800 milligrams to start with.
Well, I mean, anabolic steroids. This lady's asking about anabolic steroids and the ability to make muscle grow, and why aren't we using anabolic steroids in myositis? And that's a perfectly good question.
It did help me to begin
But I mean,
with.
the side effects aren't there? I mean, it promotes liver cancer, doesn't it?
Well, I have great liver results right here in my purse.
Okay.
But I've weaned myself off. I'm down to a very low dose now.
Okay.
But I just wondered, can't they help you?
Well, the answer to the question is nobody's used anabolic steroids in myositis yet. But I mean, that's a very good research question and one which I'm sure will be
My
addressed.
rheumatologist was very happy after
Yeah.
the first 2 weeks I was on that.
Okay. It's 3:48, and the next talk is on in 8 minutes, so we should probably stop now, unless anybody's got a burning question. Okay, thanks.